to give a meaning of what we see. That represents us a difference between vision and eyesight. As we can see in the right side of the pictures, seeing the vision chart or Snellen's chart or anything clearly just a sight, whereas I guess any of you people there have seen this picture or not. So many things can be derived. Actually, we can see that picture, but everybody has a different sense of interpreting that pictures. So can anybody tell me what they can see in that pictures, in the first picture?
I guess so. It's so difficult to recognize.
Yeah, this is a vision actually. Yeah, it's a cow. It's a cow. The backwarded directing cow with a two horn. Okay, so vision means is not a thing that we only see. It is also a thing that we can derive a meaning from the objects. Vision is ability to interpret and understand the informations that come in through the eyes to devise an appropriate response. The visual system, our visual system, utilizes a brain pathways to process and understand what the eyes sense. Unlike eyesight, there are over 20 visual skills that are required in order to have a functional visual system, representative in every lobe of the brain, along with the cerebellum and brainstem, and utilizes vision utilizes about 80% of the brain pathways. So to go into more depth, vision is very complex and highly parallel processing activity involving nearly every sense of the human being, and it has been explained, as I told, it has been explained in many ways. But one of the best definition regarding vision was given by Dr. A.M. Skeffington. The picture shown here is a photograph of Dr. A.M. Skeffington, who has given a best definition on vision. So he has explained that vision is comprises of four things. This circle is called Skeffington circle, four circles actually, and it comprises of four aspects: centering, identification, anti-gravity, and space. First, the anti-gravity aspects that defines where am I and where are my body parts on relative to other things in space. And the second things that is centering, it defines where the objects is. And the third thing is identifications, that defines the aspect what is it. And the final one is speech and auditory, or the communication system, that answers us how do I know about the things that I have seen, or what can I tell you about it. And these all four aspects comprises of vision. Again repeating: anti-gravity, centering, identification, and communicating system. These four things comprises a vision. So I'm going to discuss each and every of these circles very shortly, so that we can have a concrete idea of what is vision. The first one is anti-gravity. As the name itself does very little exactly what this circle of vision signifies. Included in the anti-gravity is everything a person uses to answer the fundamental question, where am I actually? And the sub questions included is where am I in space, and where my body parts are in reference to the other parts of me. And it is a first steps towards vision. So after anti-gravity, the centering. It is a second of the four circles of Skeffington, and it answers us the question, where is it? And this where is it defines first identifying where am I in space. I will identify the objects, and this circle also, this centering also gives us meaning that vision directs our actions. Once we know where we are and where our body parts are in space, that is through anti-gravity, we can direct our actions to that specific place in space. And centering is everything that person uses to know where something is in reference to themselves. And the fixation that we do, the convergence that we perform, are the centering. This fixation and convergence can be defined by these centering aspect of the vision. And the third one is identification. And included in this circle is everything the person used to answer the fundamental question, what is it? After finding out the answer of where am I and where is it, so now the third aspect is what is it? It is how we identify the objects we have located in space and to which we have oriented ourselves in the space. So to identify something, we must have previous experience with that objects or similar objects. And this circle of identification circle of four circles of Skeffington is a precursor of the accommodative functions. This circle defines the accommodative functions. And the final one is speech and auditory. It answers the fundamental questions. What do I know about what is going on? And it permits and provides communication skills completely unique to humans than other human beings. So all these anti-gravity, centering, identification, and speech and auditory comprises a vision. So coming to history of vision therapy has been documented its origin along with orthoptics principles by Dahal. The history goes to 1865, and after that there is a record of first orthoptics Maddox in 1919, and early optometric pioneers such as Sears, as we know, we have heard about Sears criteria, Percival's, and Skeffington also began their work in early 1990s. So after the work of Skeffington, the definitions of the vision had changed, and all these vision therapy, a complete sense of vision therapy has evolved. So Dr. A.M. Skeffington is also known as father of behavioral optometry. So what is VT? VT is an active therapy. It requires conscious participations by the patient. And different approaches is, there are different approaches used in vision therapy. Patient to use mental effort to learn specific visual response while performing a specific procedures. And other approaches is identifying correct from the incorrect response, that is giving a brain biofeedback to do the correct response by giving a person a sorts of responses to perform. So College of Optometry, Optometrist and Vision Development, COVD, it is an umbrella organization for vision therapy in the world. So it defines vision therapy as the goal of vision therapy is not to strengthen the eye muscles. Eye muscles are already incredibly strong, and the vision problems vision therapy aims to treat are rarely caused by muscle weakness, and instead vision therapy aims to retain retrain the learned aspects of vision through a recently understood concept of neuroplasticity. So there is also some concept of neuroplasticity in vision therapy. So the main thing to understand is the goal of vision therapy is not to strengthen any eye muscles. So it is neural training, basically to say. So what is the vision difference between then vision therapy and orthoptics? So vision therapy is not same as the orthoptics. Actually, orthoptics is a narrower part, whereas vision therapy is a broad sense. So vision therapy is described as being extension of traditional orthoptics, but they share a common features as non-surgical methods of visual rehabilitations. So I guess we all know that the orthoptics is derived from two words. Orthos means straight, eye straight, and opticos means eyes or sight, and it primarily addresses the oculomotor components of binocular vision in both strabismic and non-strabismic disorders. And orthoptic practice is more often under the care of an ophthalmologist, whereas vision therapy addresses a wider range of visual deficits and include rehabilitative therapies that helps patient develop or improve a wide variety of visual skills, including oculomotor dysfunction, eye coordination disorders, accommodation anomalies, strabismus, amblyopia, and there are other many.
Uh, Hello, here, sir. Sorry for interruption. Can we go a little bit slower, sir?
Okay. Yeah, so this is a difference between vision therapy and orthoptics. So also vision therapy is practiced more often, but not exclusively. But in the world, occupational therapists, and there are many other therapies, they also practice some form of vision therapy, and but it is practiced more often in optometry setting. So who would be helpful from vision therapy then? I like to say almost everybody will be helpful from vision therapy, but the subjects having non-strabismic binocular vision anomalies like convergence insufficiency, convergence excess, and different accommodations anomalies, accommodation insufficiency, accommodative excess, divergence insufficiency, divergence excess. There are many to list. And the persons having strabismus, the person with amblyopia, and the person having oculomotor dysfunctions. Oculomotor dysfunctions, like the patients having problem with saccades, and the patients having problem in pursuits, they have tracking and tracing issues. For those, the vision therapy will be very helpful. And also the person with visual perceptual dysfunction. Visual perceptual dysfunction mean to say that the child who is having learning problem in learning, problem in processing the information that is going to the eyes, but the brain is not able to process the information that is coming from eyes to the brain. So in this kind of cases also, the vision therapy will be very helpful. Also, now the scope has been very increasing, and vision therapy has been very successful in case of patients having traumatic brain injury through concussion, stroke, and also in sports vision is one of the main issues where vision therapy would very much help.
Hello, Hira sir. Hello.
Yeah. Yes.
Hello, Hira sir. Yeah, Ravi here.
Yes, sir.
So I'm still confused between orthoptics and vision therapy. So in a simpler word, if we have to explain, what is the main difference between orthoptics and vision therapy, sir?
Yeah, so Ravi sir, thank you for your question. Actually, orthoptics it only deals with oculomotor component in binocular vision. That is, especially strabismus and different non-strabismic binocular vision disorders it deals. Whereas the vision therapy is a broader sense than that. And also
So
because
sir, but in your slide, they are written it is undertaken by by ophthalmologist and vision therapy by optometrist.
No, sir. Actually, the orthoptics term I am discussing regarding the orthoptics term. Orthoptics term is mainly used by ophthalmologists, whereas the optometrist practicing these, they usually use the term vision therapy, sir.
Okay, sir. Thank you, sir. I was confused a little bit, so
I hope that helped.
Yeah.
Thank you.
Okay, thank you so much, sir.
So in these different kind of conditions, the vision therapy would be very much helpful. So let's go to the research evidence for effectiveness of vision therapy for binocular vision, accommodative and eye movement disorders. There are very much literature published in different journals that discuss about the efficiency of vision therapy in different conditions. Especially there are a few randomized trial published for convergence insufficiency and also for accommodation insufficiency. So I like to share you some of these. So effectiveness of vision therapy for convergence dysfunction and long-term stability after vision therapy. The results was that the symptom score and clinical measures of treatment and controls were not significantly different as the baseline, but showed significantly difference after the completion of 12 weeks of treatment. So the vision therapy basically helps very much in these kind of anomalies. Also, there were other studies that discuss the effectiveness of vision therapy in school children with symptomatic convergence insufficiency. The result was that the most of the participants had severe problems in near point of convergence. So after the vision therapy, the average near point of convergence improved by approximately 5.48 plus minus 0.96 centimeter in all the participants. Moreover, vision therapy had an effect on increasing the near positive fusional versions and decreasing the exophoria also. So and This is a randomized clinical trial published that discussed the usefulness of vision therapy in symptomatic convergent insufficiency children. So it discussed that after the 12 weeks of treatment, the office-based vision therapy group have significant improvement in the symptom score also, and as well as other aspects clinically. So, there is a question regarding why to go for this vision therapy, no such outcomes like that. So there are many, we can see many published literatures that discusses the usefulness of vision therapy in these different conditions. So also, as I told, the treatment of accommodative dysfunction in children, a result of randomized trial, the result was that after the treatment with vision therapy, there was very much improvement in different aspects of visual skills. So vision therapy helps in accomplishing the following in accommodative, oculomotor, and non-strabismic binocular vision disorders. That is, reducing symptoms of the patients, increasing the amplitude of accommodations, increasing accommodative facility, eliminating accommodative spasm, improving the near point of convergence, increasing fusional vergence amplitudes, increasing fusional vergence facility, and eliminating suppression, improving stereopsis, and also improving the accuracy of saccades and pursuits, and improving the stability of fixation. So these things, especially in oculomotor and patients having non-strabismic binocular vision disorders, these things can be improved through the vision therapy. So how to determine the necessity of the vision therapy, whether the vision therapy is needed for the patient or not? There is a hierarchy of examinations. So first, when the patient comes, we should go with the appropriate refractions of the patients. So first, monocular balancing, monocular as well as binocular balancing, we should perform a proper refraction. So after refraction, we should go for ocular health assessment of the patients to rule out any pathological conditions that the patient is having or not. Then after the ocular health assessment, we should go for comprehensive assessment of eye and visual system, and then the visual efficiency skills like the vergence, the accommodations, and the oculomotor skills. These are also known as visual efficiency skills, and these must be assessed. And then visual information processing if required. So this is a hierarchy that first we should not directly jump from one hierarchy to another hierarchy. For example, first we should perform a proper refraction in the patients, and then the ocular health assessment to rule out any pathology. For example, I just want to share you one case that I had few months back. A patient was the patient has had vision of 6/60 in one eye, and the vision was 6/6 in another eye, and the patient was referred as having query amblyopia and referred for the treatment for me. So on a complete, she was very young lady, about 25 to 26. On doing retinoscopy, I could not find any significant refractive error. So what I did was I just did a dilated fundus examinations, and there was macular scar in the eye with a low vision. That 6/60 vision in the eye with a vision of visual acuity of 6/60, there was macular scars. So actually we should follow this hierarchy to rule out or to decide whether the vision therapy or any visual rehabilitation interventions is required for the patient or not. So, and there are very number of factors that affects the outcome of the vision therapy. So first one is age and intelligence of the patient. So actually this vision therapy can be done in cooperative patient not in smaller children. Actually we can see three pictures in this slide. The lower one that you can see, is performing a marching ball. He's a 4.5 years old child. He was an amblyopic child, and and the intelligence of the patients, the cooperative of the patient matters very much in successful uh, dealing or treating with vision therapy. And the next factor is determination of the prognosis for particular patients and the specific problem. So this can be done by properly evaluating the patients. How can we uh, so what are the deficiencies in visual skills that the patients have, that we should determine through the comprehensive examinations, and then we can discuss a prognosis with the patients. And third one is motivations. So this is a very important aspects. For example, you find some deficit in the patient, but the patient is not very much motivated in performing or about that deficient in visual skills. Then we cannot drive to the patient in vision therapy. So the motivation factors also play very much role. So for increasing the motivation, so encouraging the patient for the treatment, so we should have proper counseling to the patient. And also the relationship between chief visual complaints and the optometric findings also should correlate to determine the successful or to improve the visual skills in the patients. And of course the time course of therapy. For example, as I'm practicing in Kathmandu, which is a capital city. We have very much large number of patients coming from outside the valley also. So for them, the office-based, especially the office-based vision therapy will be very difficult to be here, to be in this capital and do all the treatment. So the time course of therapy will also is also one of the factors that affects the successfulness or the outcome, proper outcome in uh, vision therapy. So next one I like to discuss is the tools. What are the tools used in vision therapy? So there are many tools that are can be used while performing or while initiating the vision therapy. We can make a uses of lenses. We can make a use of prisms. There are many filters, red filters, green filters, anaglyph. There are many occluders, and there are very much specialized programs. And nowadays computer programs has also been very much used in vision therapy to rehabilitate the patients. So I'm sharing you the instruments used by as enlisted in the book Mitchell, Simon and Wick. As I'll discuss in the last slide that this book clinical in this book the clinical management of binocular vision, the vision therapy tools have been listed in basically six categories. So anaglyph and Polaroid filters. The second has been categorized as lenses, prisms, and mirrors. So third one is categorized as septa and apertures. The fourth one, paper, pencil, and miscellaneous tasks, stereoscope, and after images, and the tools that use the principle of after image and entoptic phenomena. So I'll be shortly discussing with all these different kind of tools that we use in vision therapy. So first one is anaglyph and Polaroid filters. Actually, anaglyph means two filters used differently. For example, in the pictures we can see red and green filters. They can be either red and blue filters. So and Polaroid means the use of a different, as we all know, it uses a principle of polarizations, and the different instruments that falls or that different instruments that is categorized into that falls under this category are trinaglyph. In the top pictures, I guess we can see a trinaglyph. So trinaglyph, there are basically two types of trinaglyphs, variable and non-variable, and they are basically used to improve the fusional status as well as to more suppressions, fusional status, positive fusional versions as well as negative fusional versions. And the second one is a vectograms. And vectograms basically uses Polaroid filters. And the third one is bar reader. third one is bar reader. So bar reader is basically used for anti-suppression purpose. Anti-suppression, if we have to eliminate the suppression of the patients, we'll basically use the bar reader. And also the fourth one is a TV trainer. So TV trainer is basically also an anti-suppression tool that is specially used in the children. So what we do is we'll stick the two sides of the second picture is a TV trainer that we can see all ours red and blue vertically. Now what we can do is we can patch the transparent patch in the TV the child is seeing, and we can use to eliminate the separations. And there are many computer programs that are available using anaglyph principles, red, blue, or red, green, and also the computer programs that uses a Polaroid filters. As there is a software called VTS4 that I have kept in the pictures. It uses a principle of Polaroid uh, for treating all these anomalies or to improve all the visual skills of the patients. So I'm just discussing some advantages and disadvantages. The advantages of these anaglyphs, that is using to separate a field of view for the patient, is it allows good control of the stimulus parameters, and we can use a wide variety of targets. And the patient does not have to look into an instrument's procedures, and it closely resembles the normal seeing conditions. And especially I talked about that vectograms and this VTS4 that utilizes a principle of polarizations. These are very highly expensive, and so a little bit expensive to afford. So what we can do is we can utilize the principle of anaglyph, and either we can also incorporate vision therapy tools that utilizes the principle of this polarizations. And the second one is lenses, prisms, and mirrors. So there are different tools available: flip lenses, loose lenses, prisms, flip prisms, loose prisms, and prism bars, handheld mirrors. So what does these do is basically lenses, what they do is they change the accommodative demand of the patients as well as uh, Barzen's demand of the patients. If it is used basically monocularly, the lenses are used, it changes the accommodative demand of the patient. So if they are used binocularly or in the both eyes, they usually change the Barzen's demand. Whereas prisms and mirrors change the direction of the light. And these lenses, prisms, and mirror are often used in conjunction with anaglyph and Polaroid that I discussed the previous sections of vision therapy tools. And basically to discuss what are these instruments or what are these tools used. Flip lenses is basically flip lenses, and loose lenses are basically used to train. If they are used monocularly, they are used to train the accommodations, like we have procedures called lens sorting, lens rocking, split pupil rock. We have different these kind of techniques that we can perform with these flip lenses and loose lenses. And regarding the prisms, we can train the versions, and prism bars also we can train the versions of the patient. So basically the main thing is that lenses changes the accommodative demand when used monocularly, and when used binocularly, it changes the versions demand of the patient. So if we have to train the accommodative skills, we'll use the lens monocularly, and if binocularly, if we have to train the versions, we'll use the lens binocularly, or as well as we can use a prisms. So the third is Septa and Apertures. There are different instruments, tools that uses these principles. What is these procedures uses septum? These instruments uses a septum, that is a dividing wall that separates the view of each eye in normal space, so that one eye sees one portion of the target, whereas other eye sees the another. And basically there is two instruments that are frequently used in any vision therapy setup: aperture ruler and Remis separator. So this aperture ruler, that in the pictures above, it can be used to train positive fusional versions for convergence as well as divergence therapy. And these septa and apertures allows to treat shallow to moderate suppressions, but the main disadvantages in using this kind of instruments is that we must maintain a proper head position to use these instruments. If we tilt the head, it will be difficult for us to perform any activities in these instruments. So the next one is the
Okay.
paper, pencil, and
Hello, here, right?
yes, Kapil.
सेसन अलिक इन्टरेक्टिभ भएन कि त्यसमा चाहिँ मैले केही क्वेसनहरू छ भने एकछिन ब्रेक लिएर केही क्वेसनहरू गरेर फेरि अगाडि बढ्ने कि भनेर सोचे दाजु त्यस्तो गर्न सकिन्छ अहिले?
Yeah, so we have a questions. One questions. How would you approach a high myope with intermittent exotropia? And even if we correct them with appropriate refractions, they tend to exhibit exodeviations. Okay, so Murtuza. So hello Murtuza. Thank you for the questions. So what we in patients with intermittent exotropia, basically the main thing is performing a proper refractions, I guess. So after performing a proper refractions and giving the appropriate corrections, the patient has more exo. Now then we have to find out what is the accommodative status of the patient. So basically what I do is in every myopic patients, I perform a dynamic retinoscopy in a patient. So to find out how the accommodate patients is going through all these accommodate. So how the what is the accommodative status of the patients, and then after coming to the optimum prescriptions with after coming to proper prescriptions with performing all these tests, and then if there is a intermittent exotropia, then basically we first train the accommodative skills, and then we'll just go for because the patient, you told that the patient has intermittent exotropia, and we'll go for versions, positive fusional versions, and some anti-suppressions exercises that we incorporate in this.
Okay, here again adding the question there. The most maps under the under accommodated and low ACY ratio.
Yeah, so basically there is also a thing that what corrections options that you use for the patients. So basically if the patient is high myopes, then I'll go for contact lens, and then by to eliminate all these prismatic effect, to eliminate all these unwanted prismatic effect of the spectacles, and then we'll go for assessing the patients, and on the basis of what is the finding of the patients, either the patient is intermittent exotropes or the myopes, mostly they are exophores, and then we'll go for treating the patients. Basically first the accommodative skills will improvise, and then the urgency skills. So basically that will help to tackle out the intermittent exotropia the patient have.
Thank you, sir. So there is another question as well. How to use hand mirror?
Yeah, basically, can't we give a little minus overcorrections, sir? Basically, I don't prefer for minus overcorrections, because the main thing is that, for example, I gave the patient has a -2 of refractive error, and you just gave a -2.25, you overcorrected. What happens is, basically we, apart from many different distance activities, we have lots of near activities these days. So if you overcorrect the patients with more minus, as we all know that the minus lens stimulates the accommodative system of our eye. The minus lens stimulates the accommodations, so that the patient will again over accommodate for near, and the patients either develops the accommodative excess, or the patients because of the actions of ACY component, patients will over converge for near. So I don't suggest a little minus so I don't suggest any minus corrections. So to determine whether we have corrected a minus or not, again, what I do is I'll just perform with the final prescriptions in the trial frame. I just perform a dynamic retinoscopy over the final prescriptions of the patients and determine whether what is the lag of the patients. So I just maintain the patients at a normal lag of plus 0.5 to plus 0.75. So then we can then I'll finalize the prescription. So I'll take care not to overcorrect the minus prescriptions of the patient. So I see the next questions.
Okay.
How to use a handheld mirror? Basically, handheld mirror is the used for awareing the laterality, directionality of the patients. To if the child has any sorts of problem with determining the directions, right, left, right, we can use for that. Also, handheld mirror is used to make the patients aware of the eye movement. This is a simple tool that we use in the vision therapy.
Okay. There is also question, Raju. Sarita Gupta asking for questions. Thank you so much, Sarita ji. So, how to decide plus addition lens for vision therapy in esotropia?
So there is a question. So again,
Yes,
Kapil, can you repeat the question?
Yes, sir. How Sarita is asking for how to decide plus addition lens for vision therapy in esotropia.
Basically, the plus addition lenses determines what type of esotropia does the patients have, whether the patient is accommodative esotropia, what is if any esotropes come, then first we have to rule out the presence of significant refractive error. Basically, the esotropes is associated with plus refractive error. So so first we should decide what is the refractive state, and for that we have to perform a cycloplegic refractions. So after what I'll do is after performing a cycloplegic refractions for the child, and then I'll decide basically go for a full prescriptions. So after giving the full prescriptions to the patients, and after then I'll follow up the patient and see how the deviation had changed or not changed. And on the basis of that, also during after performing a cycloplegic refractions, so near visual acuity, near vision, we should check for the near vision, and on the basis of basically there is no an hard and fast rule to determine what is the amount of prescriptions to give the patients per year, and it goes on a hit and trial basis, and also what is a near visual acuity demand of the patients and near vision demand of the patients. On the basis of that, basically we'll go forward in esotropes. So I hope that answers your question.
Thank you so much, sir. Okay. तपाईँहरू कसैलाई चाहिँ केही सोध्नु मन लागेको छ भने तपाईँले चाहिँ त्यहाँ म्युट बटन छ त्यसलाई थिच्नु होला अनि तपाईँ नेपालीमै आ क्वेसन पनि सोध्न सक्नुहुन्छ केही प्रब्लम छैन वी आर लकी हिरा दाइ हियर कमसेकम नेपाली स्पिकर भएपछि हामी नेपाली बोल्न सक्छौँ सो वी क्यान कनेक्ट सो इजली कसैलाई केही भन्नु मन लागेको छ भने अदरवाइज विल बी कन्टिन्यू द प्रेजेन्टेसन Okay.
So I see no questions.
Yes, sir. You can proceed, sir.
So,
thank you, sir.
So paper, pencil, and miscellaneous tasks. So there are many instruments on this group: lifesaver cards, free space cards, eccentric circles, barrel card or 3-dot card, Brock string, and hard chart, and later tracking and tracing chart. These are basically printed on paper and designed to train versions, accommodations, and different accurate eye movement skills. And Brock string, it uses a principle of physiological diplopia. Among all the different procedures or tools that are used in vision therapy, this is the least expensive vision therapy procedures, and works especially well for convergence as well as accommodative therapy. So the next one is stereoscope, and stereoscope is designed in principle of dividing a physical space into two separate areas of visual space, each of which is visible only to one eye, and it is accomplished by dissociating the eye mechanically with the septum, especially in the Bristol stereoscope. Or there are two instruments shown in this slide. The first one is Bornello, and the lower one is gyroscope. And with stone stereoscope, it is a very heavy and it was used previously, but now it is not much used. And this stereoscope is dissociates the eye mechanically with septum, especially in Bristol stereoscope or Bornello, or there is two separate viewing tubes or mirror in Western stereoscope. And these are the most expensive vision therapy techniques, and they can be used, they can be heavy and bulky. As a result, they are basically only used for office-based therapy procedures. And this lower one, gyroscope is basically used as an anti-suppression tool. And the last one is after image entoptic phenomena and different electrophysiological techniques. And Maxwell spot, the first pictures, the Hedinger process that we can do on synaptophore, and Maxwell spot we can do in MIT. So these are especially used in the treatment of amblyopia, amblyopia subjects having eccentric fixation, anomalous correspondence, and also the auditory feedback is used with incorporating other different therapy procedures is used in the treatment of nystagmus. So what are the general principle and guidelines to perform the therapies? And first, we have to determine the level at which the patients can perform easily, and we should be aware of the frustration level of the patients. For example, we gave a patients a very higher demand during performing any procedures, but they cannot do, then they will be frustrated. And we should always use a positive reinforcement technique and maintain an effective training level and emphasize the patients that changes must occur within our own visual system. It is not that it will come as we do the procedures, but we should emphasize the patients that we should bring a change in his or her visual system. So there are many factors. The key factors is to get the patient to take responsibility of creating an internal change in his or herself. So we should make the patients aware of the goals of vision therapy. So during the examinations procedures, and that we evaluate different skills, accommodative skills, oculomotor skills, versions. During evaluating, we should make aware that the patient has, you have this kind of issues, and we should set a realistic therapy objectives, that we should not talk the higher thing, and we should maintain a flexibility with these objectives or the endpoint, like that our main aim is to improve this skills, and at the end of the sessions, then we'll be able to make these visual skills good. Like that, we have to do the counseling to the patients, and also we have to use a vision therapy technique that provide feedback to the patients. So this is a very much important thing while performing a therapy. The feedback is very important, especially there are many feedbacks that helps us in determining how is the patient responding to any vision therapy tasks. So I'll just discuss some of the feedbacks. So there are basically 7-8 feedback mechanisms. The first one is diplopia. So on performing any vision therapy things, if the patient reports a diplopia, then we can know that the patient is not aligning his or her eyes, and then we should aware the patients that you have not aligned your eyes, and then please align the eyes. We should discuss the patients like that. And in this picture I have shown this this is a Anaglyph, and this is a 500 series of Anaglyph. I guess we can see this upper square and lower circle in between the X. So this is a thing incorporated in the Anaglyph to determine whether the patient is suppressing while doing the Vergennes therapy or not. So the second the second feedback mechanism is a blur. So during on performing any procedures, if the patient's report blur, then we can determine that the patient is either over focusing or the under focusing is accommodative system. And suppressions, there are different, and regarding suppressions there are different thing incorporate in different instruments that are used to check, that are used as suppression check during performing any therapy procedures. In all, the clinicians, what if we are performing the therapy, we should identify that what the suppressions, what suppression cues are given to any therapeutic technique, and utilize these cues to make the patients aware of the suppressions. So if there is suppressions, both eyes are not, the patient is not using the both eyes if we are training the versions, and then we should make aware them that the eyes is suppressing, and then we go back and again do the things. And for the next one is a luster. Luster, what is a luster is? Luster is a perception of a combination of colors seen when the patient is asked to fuse a target of different colors. For example, in these pictures itself, Anaglyph, this is done by wearing a red and green glasses. So if the patient is able to fuse or combine the red and green images from his two eyes in the brain, the different colors will be seen. So this will be also a feedback mechanism for us that the patient is using both the eyes during the therapy procedure. So the diplopia, blur, suppression, and lusters, and also kinesthetic awareness. Kinesthetic awareness is the sensing and awareness of the sensation of accommodating and conversing during performing any therapy procedures. We can also utilize this feedback mechanism to attain, and it also helps to redirect to us that whether the patient is performing the therapy procedures properly or not. And again, the next important one feedback mechanism that is used in vision therapy is silo response. Silo response, it is basically based on, I just uh, so it is basically based on a size constancy principle. So the first picture is a typical representation of small in. Silo means small in and large out. So what is in the first picture, what we can see is uh, during any therapy procedures, when the patients converse, and when the observers accommodates and converse during the therapy procedures, the objects or the things, the pictures approaches near the patients, towards the patients, and the retinal image sizes increases. So what our visual system or the perceptual system is, so the perceptual system tries to make a correction of that increase in size corrections by using a principle, by using a size constancy mechanism. And the image's size, or if the patient is conversing, the size of the image starts appearing smaller. So this is called small in. So again, I'll like to repeat it again. So when an observer converses or accommodates and the objects starts approaching towards the patients, the retinal size increases. So on the basis of size constancy, what our perceptual system is, the perceptual system makes corrections to maintain a size constancy, and we see the the image smaller. So this is called small in. And the second picture is large out. Large out means again, as the objects, as we relax the accommodations and diverges, the objects is moved farther away, and the retinal image sizes decreases. And utilizing this phenomenon of size constancy, our visual system or the perceptual system expands the image, and we see the images being large. So, for example, we are doing convergence therapy in Anaglyph itself, and if the patient is reporting us that the objects is becoming smaller and approaching towards us, it guides us that the patient is the patient is using his convergence. Patient is the convergence is being trained, or the positive fusional vergence is being trained. Again, if the patient reports the objects is going farther away, and then the objects is becoming larger, then we can know that um, the divergence or negative fusional patient is utilizing the negative fusional versions, or we are training the negative fusional versions, or the patient is being trained on negative fusional versions. So this is one of the most important feedback mechanism that is used in vision therapy. So again, when an observer, so this is a discussed part. So the next feedback is fluid mechanism. So perceptions that the target is floating closer or farther away as the demand is changed from convergence to divergence. As discussed, in convergence, the targets appear to float closer, and in divergence, the targets appears to float farther. Again, when performing Anaglyph, I can be able to go with that. And the next feedback is localizations. And what the localization means is the ability of the patients to point where the target appears to be when the fusion occurs. So as we can see in a picture that I have a little patient. She was a case of divergence excess uh, type of exotropia, and on performing a Brock string, I asked her to fixate on nearest bead that she is seeing, and I gave her a small red sticks, and I asked her to point at what point she is seeing. So if the patient is properly able to localize the point at which the fusion has occurred, then we'll be able to know that the response is okay or not okay. So we'll be able to determine whether we are on our track or not. So the next is parallax. It is an appreciation of the movement of fused targets as the patients move. So if the patients again during any vergence therapy that we do, if the patients appreciates a movement of a target along with the movement of the head in same direction or different directions, whether the object is moving in the same directions or the opposite directions, we can know whether the patient is using his convergence system or the divergence system during training. So these are the different feedbacks that we utilize while performing any vision therapy procedures. Diplopia and the blur, separations, the luster, the kinesthetic awareness, and the Shiloh response, and fluid and localization, and the parallax. So we utilize these and different uh, feedback mechanisms during performing any vision therapy procedures. So what are the factors that determine a successful vision therapy and accurate diagnosis of the patient's visual problems? So it is very much important to properly evaluate every skills of the patients and to diagnose the patients, because the way because every treatment, the treatment of different anomalies is on a different way. Especially I'm talking basically on non-strabismic binocular vision anomalies here. So if we diagnose the patients with convergent insufficiency, and then we treat them in a line of convergent insufficiency. If we diagnose the patients is having an accommodative excess, and we treat the patients on that different treatment protocol. So proper diagnosis. For example, if we diagnose the patients as accommodative excess and we treat the accommodative excess, but we find that the patient is not symptomatically improving, then we have to know that there is something wrong in the diagnosis. So proper diagnosis is very important to initiate and discuss regarding the management plan to the patients. So the next thing is careful selection of visual procedures to best remediate the problems. For example, I just in that Anaglyph and Polaroid techniques, we just had a TB trainer there. For example, we have a strabismic child, we have to eliminate the suppression of a child first. Then what we have to do is we have to utilize the different tools that is interesting to the child also, so that the child can cooperate and properly during the therapy procedures, and we could be successful. So a careful selection of visual procedures is also very much important. And the third thing is a collection of visual procedures that facilitate the transfer of learned skills to the patient's own visual role. For example, the patients, for example, as I discussed, septum section and aperture rule, the patient shows very much good convergence and divergence and range in aperture rule, but during his usual performing tasks, the patient is not properly able to do, then there might be a problem and we should use that kind of procedures that facilitate the patient's learned visual skills to use in his or her own world. So these are the factors, key elements during performing any therapy procedures. Again, I like to highlight the usefulness of accurate diagnosis of the patient. So maybe in the next sections we can discuss regarding the diagnosis of different non-strabismic binocular vision anomalies. So how to start? So how to start a vision therapy practice then? So I hope many of us has gone or not. There is a article by Dr. Mark on Optometry Times in 2014 August. Top 10 must have list for performing vision therapy, because the main thing is that we can utilize any tools, don't require anything. It just required any space and a practitioner and a patient. So we can utilize any tools to perform therapy procedures, but the main thing is proper utilization of concept and proper redirecting the concept into the practical aspect while doing the therapy. So I just want to highlight these 10 vision therapy tools that was discussed by Dr. Mark in that article. So the list were wolf wand, heart chart, and Brock string. So wolf wand, as we can see in the middle pictures, this is a pictures of a wolf wand. So what is this wolf wand is? This is basically a two stick that is available either in a red and green or a golden and silver color. These are basically used to check the oculomotor skills, basically a saccades, and also we can utilize it to the uh, assessment of pursuits and pursuit skills, and also it can be used in assessing different feedback mechanism. I told it can be utilized in localization aspect of the patient. And the second tool that he has discussed is the heart chart. As we all know that heart chart is used basically for an accommodative therapy, the distance heart chart, the near heart chart, and the third one is a Brock string. And Brock string is an excellent tool which basically used in vision therapy practice. It is, as we all know, it utilizes a principle of physiological diplopia. So there are string with different color beads. Basically, what we do is we use a single bead during the regular optometric practice, but the main thing in Brock string that we can also train an oculomotor skills. We can also use in patient with diplopia by using different two or more Brock string in different gauges. So this is we can use in many way to treat the different anomalies or to improvise the different skills that is the patient is deficient in by using this Brock string.
Okay, sir, what is the difference between if you use the by the 6-meter block string or 1-meter block string is usually on practice?
So basically, what is ideal thing is that there is no ideal thing in a Brock string. There is one story in Brock string. Actually, I want to share with you. Actually, Brock string is a name of it is named after Dr. Fred Brock. Actually, he was strabismus by himself, and he treated at that time. Basically, I guess it was in early 90s, and he treated his strabismus by utilizing this string with different color beads. So the name has been given Brock string. So regarding the question the Kapil has, basically, actually there are different. Ideally, the Brock string comes with a distance. There is a Brock string by Bernal company that that has a large volume of distribution of vision therapy instruments around the world. It has ideally a Brock string of 3 meters, and these three different color bits. Basically, if you use a large or long Brock string with a large bits, then you can you train a patient on a longer range. And if you use a Brock string with a small bits and shorter Brock string with a small bits, you can only train a patient in the shorter range. So basically, the ideal thing is to use a Brock string of 3 meter with a medium size beads. So
Okay.
I hope
So
that
what
answers.
what is it mean by the medium size? In 2 millimeter of beads or 2 centimeter of beads?
2 centimeter. Basically, the pictures that has shown, basically it is a 3 meter bead, and you can see the size of the beads. And it's not too small also. It not too large also. Basically, I haven't measured that accurate size of the bead, but medium size means, I guess, the more than the diameter around 2 centimeter, 2 to 3 centimeter of the bead. But you can utilize any depending upon the feasibility or the availability of the string to you, of the bead to you.
Okay. Okay. Thank you, sir.
So Wolf wand, hard chart, and the Brock string.
So may I ask one
So
question?
the
I have one curiosity
yeah
regarding the Brock string. So why basically the Brock string was prescribed for all type of like fusional insufficiency, accommodation, and as well as convergence. So why it is used for all type of
yeah, actually, I just want to highlight one thing. I don't think there is any written anywhere that Brock string is used to train accommodation. Yeah, Brock string is used to train accommodation, yes. But if you have a letter printed over a beads, then it is used to train the accommodative skills of the patients along with versions. Unless you don't print anything in the beads, and usually the use the beads, it is only used to train the versions of the patient. It is not used to train the accommodative skills, or used to train the accommodation of the patients.
Okay, thank you.
So the next thing that he has discussed is a Marsden ball. Yeah, Marsden ball. Yeah, we can see it is a small, medium-sized ball. I guess about 6 to 7 or 10 centimeter diameter ball that can be hung into the wall, and it has been it can be used again like a Brock string. It can be used to train the oculomotor skills of the patients, to train eye-hand coordinations of the patients. So there are many things that can be used with a Marsden ball. And the next one is, the fifth one is vectograph. As we can see on the right hand upper pictures of the vectograph, it utilizes a Polaroid. We use a Polaroid filters, Polaroid glasses, and it is used to train the versions of the patients. And the next excellent tool that he has discussed is balance board. So balance board is basically, it is used in case with perceptual disorders, or the child has visual perceptual dysfunction. If the child has a problem in laterality means visual spatial skills. The patient, the body is not properly balanced, so there is a problem with spatial localization of the patient. So in these all kind of activities, we basically use a balance board as a tool to in vision therapy. And the next one that he has discussed is a pegboard rotator. This is the large picture that in the left side is a pegboard rotator. It is an excellent tool that can be used to train the oculomotor skills, saccades, pursuits, especially also the eye-hand coordination of the patients. And you can see the rotator is printed with a red and a green line there. So also what we can do is we can use a red green glasses over the patients and monitor the suppressions during all these activities. And the next thing is excellent tool is lenses and prisms. As I has discussed, the lenses, the usefulness of lenses, the usefulness of prisms in vision therapy, and the rotator glasses. The pictures on the rotator glasses is basically a prism trial glasses. We can utilize is a basically a yoke prism, then monocular prism, which we can utilize as a yoke prism in treating the patients. Basically, these rotator glasses and yoke prism are used in patients with different perceptual disorders, like again special populations like autism spectrum, the child with autism spectrum disorders, especially the person having traumatic brain injury. We can utilize these rotator glasses or the prism goggles to train or to do these things. So, and the next one is computer programs. So computer programs, as I discussed in the Anaglyph and Polaroid section, there are different computer programs that actually it is a tool that has many different sections, and we can use according to our need to train different skills of the patients. There are different in Nepal, basically two computer programs are very much used. The first one is VTS. The latest version is VTS Pro, and also Sanit Vision Integrator, SVI. It is called SVI. It can be, it has been used. Also, the latest one that has arrived in Nepal is Visio Prime, that utilizes, that is also utilizes a principle of Anaglyph, that utilizes a red and blue filters. We during training all these we can train accommodations, we can train the versions, conversions, positive fusional versions, negative fusional versions. Also, there are many perceptual therapy, motor therapy, eye-hand coordination therapy that can be that has been incorporated basically on these computer programs. So basically, these are the things basically he's discussed. The Wolfwand heart chart, bro. I think you can get this article on the internet also. Wolfwand heart chart, Brock string, Marsden ball, vectograph, balance board, the rotator, the lenses and prisms, and the rotator glasses, and the computer programs. So if anybody, I guess all optometrists, practicing optometrists are very much keen interested to start their vision therapy practice. So this is very good. So I think it is one of the best subspecialty, although other subspecialty is also very good. The satisfaction that you have with this subspecialty is very great. So if anybody is interested, so for further readings, for the beginners, especially for the beginners, I request you can keep the two books as a references. One is Clinical Management of Binocular Vision by Mitchell Simon and Bruce Wick, and the next one is Applied Concept in Vision Therapy by Dr. Press. So you can keep a reference of these two books and then start working. And there are different websites also available. Basically, the umbrella organizations of the professionals that are involved in vision therapy practice is COVD, College of Optometry and Vision Development. And also in Australia, there is Australian College of Behavioral Optometrist, and OPEF, Optometry Program Extension Foundation. These are three different websites that you can log on and get the different knowledge, or get the different understanding in this field of vision therapy. And also, I request anybody interested users to go with these full list of there are full list of journals that basically publishes or have a publications of these subspecialty of vision therapy or behavioral optometry. Journal of Behavioral Optometry. Actually, it has been the publications of these Journal of Behavioral Optometry has been stopped from 2007. Also, the previous from 1980s or 90s to 2007, they have excellent publications, and you can find many numerous procedures and good articles, good reference materials for clinical practice in vision therapy. And the next one is Optometry and Vision Development. Also, its publication has been stopped till from 2007, and Optometry and Visual Performance and Vision Development and Rehabilitation. So these are the 4 journals that you can take a reference to enlighten yourself in this field of vision therapy. So thank you for your attention. So if you have any further queries regarding all these management of the cases and all these things, you just can mail any queries at my mail address.
Thank you so much, sir. It's a nice presentation. It would be so difficult to find all the vision therapy kids and discussing on a single presentation. So it was indeed very nice presentation. So once again, thank you so much, Hira sir, and all the attendees for their attention and passion. So if you have any questions,
so I just want to go for yeah. So I just have a question from Murtuza. Hello, Murtuza. Yeah. So he has a question regarding, can you also discuss the management of strabismus, large angle tropias, and muscle paralysis with VT? Yeah, so basically the area of scope of VT lies very good in case of patient with strabismus, in esotropia also, and in exotropia also. In going from esotropia, basically there are different approaches. So I just want to share you that there are different approaches. So how will you like to approach the patients? So in esotropes, for example, the first one is the proper refractive corrections. So if the patients required additions, you will go with that additions. And then if the binocular single vision or is appreciated, or we can gain the BSV through the refractive correction itself, then there is a point in training only accommodation and versions in these patients. So after the next if the corrections or the deviations is not properly corrected, even though with the proper spectacle corrections, then we need to go for first, in managing every cases with vision therapy, first we have to analyze we have to make a proper evaluation. For example, in the strabismic case, there will be suppression. Either central, we have to determine whether the fixation is suppression is deep suppressions or superficial suppressions, and then we have to evaluate the fixation pattern of the deviated eye, and we have to also check the oculomotor skills. We have to also check the accommodative skills of the patients. And the first main thing in managing the strabismus with BT is the anti-suppression thing. First, we have to perform an anti-suppression therapies first to eliminate the suppressions, because once the suppressions will be eliminated, and but the main thing is the disadvantages in this is, once we get to eliminate the suppression of the patients, the patient will have diplopia, and we can utilize a prism to eliminate the diplopia. And after doing the anti-suppression procedures, then we have to train the versions of the patients. So this is how basically we approach patients with large angle strabismus. First, the anti-suppressions. So once the suppressions has been, basically takes about 3 months. The time range is very high. It is very basically a challenging thing to eliminate the suppressions. The time frame is about 6 weeks to 3 months to eliminate the suppressions. We have to work very hard. So after eliminating the suppressions, and then if the patients will have diplopia, then we have to eliminate it through prisms, and then we have to work on versions. And basically after on going through, the diplopia will also be decreased, and then finally we can rehabilitate the patients. And your next question is on muscle paralysis. Yeah, so muscle paralysis is also first we have to determine what is a cause. In muscle paralysis, basically the cause is neurological. So we have to determine any pathological conditions in the brain or not, in neurological side or not. So if there is any pathological conditions, first we have to treat that pathological conditions. So the main thing is the in patient with paralysis is the diplopia. So recently I had an pediatrician who would to do very fine surgery, and he had a diplopia. So first thing is we have to rule out the pathological conditions and then eliminate the diplopia with suitable use of prisms, and then we have to go on with the VT. Basically, the paralysis cases, eliminating the pathological conditions is very necessary. For example, the patients with uncontrolled diabetes has had a muscle paralysis, and then it's not a rational to start the VT once until the level of diabetes of the patients has been controlled. So
Okay,
I find the next. I hope that has answered your question.
Yes, there is one question from the Wrinkle sir. Could you share us some of your good experience with binasal occlusion?
Yeah, oh my God. Actually, binasal occlusion is a very useful tool for rehabilitating the patients. Basically, it has different works. We can, again, I like to tell there are many approaches that how we go with the treatment of the patients. Binasal occlusion, the main thing is it is used in isotropic patients and and also it has been very successfully used in patients with amblyopes. And the main thing is to eliminate that suppressions and to eliminate a visual noise that is coming from the suppressed side of the patients, and also to make the patients able to alternately fixate the eyes. And so there are basically various uses of binasal occlusion. Also, what I do is I utilizes the very much its use is very much high in the case of intermittent exotropes also. So
okay,
actually the scope is of binasal occlusions is very large. The discussions will not end, I guess, in these few hour sessions. So maybe I can share my experience with Wrinkle sir then in the next day to come with him.
Okay, thank you, sir. Sir, some of in our previous presentation, one of attendees asked a question. Some of the people also use the binocular occlusion as a myopia control. So, how we could use this binocular occlusion as a myopia control?
Actually, I don't have that experience in using binasal occlusion for myopia control. But the main thing is for myopia control is to work on peripheral hyperopic defocus that the patient has. I don't think there is a role of binasal occlusions. Whose questions was that, Kapil? Maybe I can get him afterwards with these presentations on going through all the available things.
If Kamal Bhai is here, Kamal,
actually, I haven't heard it is.
Actually, Kamal
So
was
yeah.
Okay. So when Kamal was giving a presentation, we doing a presentation on myopia control, and some of the attendees asking the question. Exactly, I don't remember who is asking. I guess our Chandan Mohato was asking this question. I guess last I remember. I know Rinka, and he on his he has a fellowship on vision therapy training on autopsy children. So can you share some of your experience in the life?
Yeah, maybe we can hear something from Wrinkle also.
Okay. Yes.
Hi, Hira.
Hello, sir.
Could you hear me?
Gauri sir.
Yeah, sir. I can hear you, sir. It's good to hear you, sir.
In fact, just not. It was not just the introductory, the topic. I feel you have covered exclusively the different techniques and the techniques of the vision therapies.
Yes, sir.
So I just again, I'm just going to ask you just very general questions. Like I was just assuming that the vision therapy we're talking about is, I think, this using both the sensory and motor part of the visual systems.
Yes, sir.
I just like to ask you, in your experience, which part of these visual systems become robust with the VT? Is the sensory part or the motor part, or are equally improved with the VT?
So basically, the sensory part is very important, because the sensory adaptations the patient has, especially in case of strabismus, the suppressions, the eccentric fixations, the anomalous retinal correspondence. So basically, we basically utilizes the sensory part, but not keeping alone the motor part. We basically incorporate better half the sensory part, and then the less half the motor parts.
So okay, then one more questions, just adjoining to this, to this, like you say about the sensory stimulations, like how we measure that there is a definite improvement in sensory system. This might be the reason that some people might have developed a skill to cope with that deficit by using the functional part of the visual areas.
Yeah, so thank you for your very good questions. So basically, on talking with suppressions, for example, I just want to share my experience with suppression. So basically, the main tool to determine the amount of suppressions, the suppression scotoma, is utilization of Worthford dot test. So basically, what we do is, we perform a Worthford dot test at different distances, from near to distances. So, and it determine also in the ambient illuminations and in the properly illuminated conditions, light conditions and dark conditions. So on performing a Worthford dot test in light conditions, dark conditions, and in different distances, we'll be able to make a complete idea of what is the depth of the suppressions the patient has, and what is the amount of suppression scotoma on the patient has. So on subsequently performing the anti-suppression exercises, so we'll evaluate the response of the patients in these different conditions, and we'll get to know so how the patient is improving or not. We'll go with that, sir.
Okay, then that's really good. Okay, thanks for this.
Thank you, sir. Thank you, sir. So now I have a next question from Basanta, sir. So what is the role of heart chart? So Basant, sir, heart chart is basically it can be used in many ways. We can use a multiple heart chart to train an oculomotor skills of the patients. Also, we can train an eye-hand coordination by asking the patient to toss the letter that he is reading, and also we can utilize a heart chart, near heart chart distance heart chart, to train the accommodative status of the patient. So it can be used in many ways, sir. So the next questions I have is, so what should be the ideal spacing between two beads in the Brock string? So thank you, Ranjila Sangbo, for the questions. But there is no hard and fast rule that what should be the ideal spacing. The main thing is that at what distance from the eye we are training the versions of the patients. So if we are basically the spacing between the Brock string depends upon is used used or plays very much significant role when training the jump versions in the patients. So how long or in what distance or how long you have to train the jump versions. So the distance between the string depends on that. So there is not an ideal space in keeping Brock string. We can keep either in front of rear to our eyes, or we can keep it farther. It depends on what visual skills that you are trying to improve. So next questions, I hope that answers your questions. So the next questions I have is, what can be the suggestion for training patients of different ages and scheduling for vision therapy? Yeah, so Ananta, very good question. So basically, there are two phases in vision therapy aspects. One is home-based, and the next thing is office-based. So basically, the scheduling depends upon how far is the patient, how motivated is the patient, and what is the treatment time that you have to improve the visual skills that the patients have. For example, basically what we utilize is the patient. We have some home therapy tools for the patients. We guide them to do that activities at least 20 minutes in a day at home, and we go for 2 visits in a week for 6 weeks or 12 weeks, depending on the improvement, for example. And then we do the reassessment of the patients after 6 weeks. That is, after every 12 visits of the office therapy, we do the reassessment of the patients, and we'll decide how to go further in these vision therapy. So I hope that answers your question. So Nandi, so what are the treatment steps to be followed while treating the patients with microtropia? Yeah, again, to answer that question, the main thing, first we have to determine whether the patients with microtropia has eccentric fixation or not. So if the patient has eccentric fixation, we have to eliminate that eccentric fixation first. And then we can use many tools like Hedinger process, Maxwell spot, and past pointing activities to eliminate or to train. Also, basically, in theoretically, there is something called pleoptics, but that has not been properly, that is not being practiced here in Nepal, I guess. And so first you have to train, work on eccentric fixation, and then after eccentric fixation, and then you have to check for suppression. So what is the amount of suppressions? As I discussed, you can check the suppression status of the patients from the Watford dot test by doing the Watford dot test in dark conditions, in light conditions, and doing the Watford dot test at different distances. You can utilize and check what is the suppression scotoma of the patients and determine the suppression status, and then we go for suppressions, anti-suppressions thing. So after the suppressions is over, if the patient has, maybe the microtropia patients won't have a diplopia, and then you can go for a versions thing. So first determine whether the patient has eccentric fixation or not, and then go for a suppression thing, and then the versions thing.
Thank you so much, sir. I have one.
Hi, Hira.
What? Yes, yes.
Yes, sir.
Sorry,
Yes,
again,
sir.
I came back.
Yes, sir.
Sorry, again, I came back. I feel
Okay.
that
Yes, sir. Okay,
vision
sir.
therapy, the main challenge to the vision therapy is one of the factor is the compliance to the vision therapy there, because there are so many factors involved with the compliance. So I just want to ask
Yes,
you
sir.
that what strategy do you use to improve the compliance of those people who
Yeah.
are in the VT?
So the main thing, what the strategy I use is during first assessment, and the main thing in treatment, the initial treatment is through the proper refractive corrections of the patients. So during the refractive corrections, so I counsel the patients regarding the usefulness of all these procedures for your child or for you. And then I ask the patients to come follow up and see the changes. What are the visual efficiency skills changes? What are the visual skills the changes that the refractive corrections will alone cause in the patients. So if the patient is very much motivated with all these things, then we'll have a good follow-up on the proper time, and then we can it also shows that the patient's motivation status and the compliance thing. Also in case of amblyopia, so the basically VT is all about active vision therapy procedures, and in a child with amblyopes, along with the refractive prescriptions of proper optimum refractive prescriptions, what I suggest a patients to do some placebo exercises, like some putting beads in a needle, circling the O's in the newspaper, and then on the subsequent follow-up to see the changes in the skills of the visual skills of the patients on the next follow-up. So if whether the patient has been properly following the guidelines or the things that I have given to him or not, so on the basis of that, so I can determine whether the patient is properly, whether the patients will have proper compliance with the active vision therapy procedures that will going to the in the next step to the patient. So that is what I use, sir.
So I mean that do you send reminder calls or any message to the family member of
Yeah.
the person who is going in the therapy, like giving you reminder calls, appointment calls,
Yeah.
or the
Yeah. Yes,
just
sir. For that, I just.
okay.
Yes, sir. For that, what I do is I just keep in a touch with the direct touch with the patients those who require an active vision therapy procedure, because the number of patients will not be that very much. So on, I just give them my WhatsApp number and just communicate them frequently on the WhatsApp to determine the status of the patients or make a proper appointment to the patients and discussion regarding the vision therapy, sir.
Okay. So, and my final questions, just not the questions, but my curiosity is that, so some people like might go undergo for the strabismus surgery and later develop the intractable diplopia. Is
Yes,
there
sir.
any method that can be used to eliminate that kind of diplopia, post-surgical diplopia?
Yeah, sir. Actually, the main thing here, I have pretty much 2 to 3 patients on this, sir. So they had a very large angle of strabismus. The main question here is whether the visual acuity of the one eye basically is good or not in comparison to the another eye. If the visual acuity of the patients will is very poor, then the problems of this diplopia will not happen very often. But in case the visual acuity, like in alternate exotropes case, and the visual acuity of the two eyes same, then first will I what I do is I just uh, determine the diplopia, the amount of diplopia in vertical and horizontal meridian or directions. So what is the amount of diplopia in horizontal and what is the amount of diplopia in vertical directions? And then first, if the patient has intractable diplopia, if then first I go for vertically correcting the diplopia, and then after vertically correcting the diplopia, and then we'll work on horizontal things, because as we all know that the horizontal reserve of the patient is very high and the vertical reserve is very low. So if the patient will have intractable diplopia, basically if it is horizontal one, we'll go for horizontal prescriptions of horizontal prisms. And if the diplopia is has both horizontal and vertical component, but the vertical component is very large, and then we'll go for vertical prisms in those cases.
Okay, thank you.
Okay, sir.
Okay.
So I have next questions.
Can we make
From
can we make a little bit shorter, to describe, because it's been already.
yeah, okay.
Yes.
Okay, so I'll take 2 to 3 questions only now. Other than primitive treatment of amblyopia like full refractive correction with occlusion, prisms, mydriatic troughs including, is there any therapy for? Yeah, there is. The main thing, yes, the Vivek Kumar Bhuzel, a question. Actually, the main thing is first we have to evaluate the complete visual skills of the patients. So what deficient, in what aspects the patients or a child is deficient. So actually there are two factors in amblyopia, acuity factor and non-acuity factor. So vision therapy basically deals with non-acuity factors like the oculomotor skills, the suppression thing, and these all things. Yeah, basically there are many tools that can be pretty much utilized in the improving the visual acuity status or the improving the amblyopic patients. So I can see next question. I hope that helped. I can see next questions by Chandan. Hello Chandan. How to approach autism and cerebral palsy patient? Are Babu, which all therapy required are for proper management. Actually, the approach for autism and cerebral palsy is very used. Actually, there are very pretty number of books that deals with or treatment approach. So if you want to go for, I suggest you go through yourself. If you want to go for determining the proper approach, I suggest you to go through one book by Dr. Kaplan, Seeing Through New Eyes. That books discuss the utilization of vision therapy and what is the approach for the child with autism and cerebral palsy. So the answering to your questions now will be very vague. So now the last questions I have is, suppose the patient have one eye amblyopia and other eye normal or emmetropic. Is there any chance that normal eye will go reverse amblyopia? So basically, in theoretically, I just say theoretically, but we haven't seen it practically. If you treat a patient with full-time occlusion of the normal eye or the good eye, then you can have an occlusion amblyopia in the normal eye. Otherwise, I don't think there is any chance of having developing amblyopia in the normal eye.
Okay. Okay. Is there any question left? Okay. Before, I guess we have answered many of the queries, and considering the time limits, here I announce the close of discussion. Can we close the discussion here, sir?
Yeah. Sure. I hope the questions has been answered. Or anybody has the questions, you can just mail me the queries on my email address so that I can answer you back and in very detail.
Okay. Herewith I am ending the today's session. Before that, ending the today's session, I would like I would like to express my sincere gratitude towards presenter Mr. Hira Dahal sir and all the attendees, and also I would like to appreciate all the helping hands for this technology program. Herewith I am ending the today's session, and furthermore, I would like to request to all, please drop your review and feedback. तपाईँले त्यहाँ मैले मेसेन्जरको ग्रुपमा चाहिँ मैले तपाईँहरूलाई त्यसको एउटा फाइल हुन्छ, त्यसमा चाहिँ तपाईँहरूको भ्यू, तपाईँले कति कति मार्क्स दिनुहुन्छ आज प्रेजेन्टेसनमा तपाईँको क्वेसनहरू छ, त्यसलाई चाहिँ पालो पालो भरेर सबमिट गरिदिनु हुनको लागि चाहिँ म हार्दिक अनुरोध गर्न चाहन्छु. यति भन्दै स्टे सेफ एन्ड किप इन टच. थ्याङ्क यू हिरा सर.
Okay.
Thank you so much.